Good evening, everyone. And in coming 20-30 minutes, we will see what is this immune checkpoint inhibition in hepatocellular carcinoma is concerned. Well, hepatocellular carcinoma is not an easy disease to handle in comparison to other malignancies. The reason being here, liver is a target organ, and hepatocellular carcinoma occurs in a diseased liver. So there are two problems. Number one is chronic liver disease. We classify it into child pug A, B, C, depending on the extent of damage or extent of liver dysfunction. And number two is cancer. So we need to identify patients who have at least a child pug A or B before we even speak of a anti-cancer therapy in a liver cancer. So treating liver cancer is far difficult than any other cancer because it happens in a diseased liver. And liver is an important organ to metabolize whatever drugs we give. So we need to have a proper functioning liver before we embark onto any systemic therapy as far as HCC is concerned. So you can see the hepatocellular carcinoma. What is important is we usually classify HCC based on the BCLC staging. Having said that, you can see that even after resection, 50% of patients do relapse. Even if you pick up HCC in an early stage, even if you do a resection, majority of them, nearly 50% of them are going to relapse. And median time to relapse is less than 3 years. So you can see the survival just drops down. If it is A, B, C, or D, you can see the survival is just 25% the moment it comes down to stage C. So this is a difficult to treat disease, difficult to monitor, difficult to diagnose, and we hardly have targets as far as liver cancer is concerned. So the main pathways for HCC are the VEGF pathway, where we use drugs like bevacizumab or VEGF blockers like lenvatinib and sorafenib. And the second pathway is the immunological pathway, where we use the PD-L1 or the PD-1 blockers. So these are the only two ways of systemic therapy or targets which we have. These are these are chemotherapy resistant malignancies where conventional chemo is not the standard of care. So these are difficult to treat diseases, and we have hardly a couple of targets with which we can prolong survival. So going further, you can see this is a child pug classification. What I would like to highlight in child pug classification is, even if you don't have any encephalopathy, still you need to count as one. Even if ascites is absent, we have to give 1 point to it. And so it is not counted as zero. The least point that you have to that you have to give is 1 point. If there is no ascites in mind, I cannot calculate the zero and I cannot count it. So I need to give 1 point, even if it is normal. So therefore, child pug A, where it's a compensated cirrhosis, is where you can see just 5 to 6 points only. So at least one abnormality will classify to good risk or a class A. The moment it becomes two, at least two of them are abnormal, then it becomes moderate, and then 7 to 9 becomes moderate, and the moment it becomes child pug C, it becomes poor risk. So whatever evidence we have for anti-cancer therapy is mainly in child pug A, and nowadays we have evidences even for child pug B, a very handful of trials, including checkpoint inhibitors, where they have shown some promise even in child pug B category as well. So this is the gold standard chart we have all been seeing while managing HCC. Even today, one of the how much ever you practice, we all look into this chart before we assess what treatment we need to give to this patient. What you can see is if it is a single lesion and less than 2 centimeters in this set of patients, we can do resection provided the patient has not got significant chronic liver disease. Resection is an option only if it is a single lesion and it is less than 2 centimeters. It's not how large the lesion is, it's how much liver, functional liver I can leave back. So we always assess what is known as the FLR before we resect the lesion. If the FLR has to be increased, then we do what is known as portal vein embolization. And then we hypertrophy the existing normal liver and then we try and resect. So resection is mainly for a single lesion less than 2 centimeters. The moment it becomes multiple lesion or uh, at least they have to be less than up to 3 nodules and less than 3 centimeters, then you can see here if the portal pressure bilirubin is increased, then there is transplantation. So liver transplant can be done again, not in multiple foci. You at least have to be three and less than 3 centimeters. Again, these are soft markers. Some do, some also offer transplant even if it's less than 5 centimeters. But having said that, 3 centimeter, 3 nodule, early stage, you can do a transplant. So we hardly come across very early stage and early stage. As far as HCC is concerned, we usually come across child pug B and child pug BCLCs B and BCLC C. So BCLC D is child pug C, and we offer only best supportive care because the moment it is BCLC D, there the killer is chronic liver disease and not the cancer in itself. The liver is so much decompensated that anti-cancer therapy may not benefit or he may not be able to tolerate. So BCLC-D is out. What we are left with is BCLC-B and BCLC-C. We usually come across these two stages, B and C. So either if we treat BCLCB only with systemic therapy, we have multinodular and no portal invasion or no extrahepatic spread. In this set of patients, if I give only systemic therapy with sorafenib, lenvatinib, or immunotherapy, I will be doing an inferior treatment. I need to always pick up patients of BCLCB uh, 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 so that local therapies, especially what we call as TACE, transarterial chemoembolization, this would definitely have an impact on survival. We can see if I treat with some local therapy, especially chemoembolization, I use TACE plus RT, or I use TACE plus microwave ablation. So these local therapies would significantly have an impact on survival. So I should not be treating a multinodular HCC who is otherwise BCLCB with only a systemic therapy. On that occasion, I would be doing an inferior therapy. I always need to check out, is this patient eligible for any sort of local therapies, whether it is TACE or SBRT, or whether it is TACE plus microwave ablation or a RFA. So some sort of local therapy in a BCLCB would improve survival. I would have difficulties in giving local therapies if there is portal vein invasion or a portal vein thrombosis is there, then it would be difficult for me to give a TACE. Again, if you look into TACE, we do TACE either with the chemotherapy or what we call as DEP TACE, or we do a bland embolization, or we do a radio embolization. Whatever evidence we have is mainly with TACE, transarterial chemoembolization. So we have strong evidence, because whatever evidence we have is mainly with TACE. So TACE, if the size of the tumor is larger, then I would add TACE plus local therapy like a RT, or I would add a microwave ablation or RFA. So so the take-home message is we always need to pick up patients on BCLCB and expose them to some sort of local therapy. Only if local therapies have failed or have progressed, then I would like to give systemic therapy. So on the other hand, if you have a patient of BCLCC who has a lot of extravascular disease, extrahepatic disease, like lung mets or a large retroperitoneal lymph node mets or peritoneal disease, or I have a patient who has a portal vein thrombosis or a major vessel involvement, which would otherwise hamper me from giving local therapy. I should not be unnecessarily subjecting these patients for local therapies, because these are biologically difficult diseases for any local control. Already there is sufficient extrahepatic spread. I need to give them only systemic therapy. So we need to be very judicious in offering which patient should go for local therapy, especially TACE, and which patient has to go only for systemic therapy. So many times in practice, the chemoembolization happens first, and then when they progress, it becomes systemic therapy. The other way is quite rare. I give some sort of TKI, some sort of lenvatinib or sorafenib or immuno, and then they become eligible for chemoembolization. This is quite rare. But with the presence of now effective therapies like we have Nivo EP or Atizobay, or we have lenvatinib doing quite well. So we may have some select subgroup of patients again going for local therapy when we are able to control the extrahepatic disease well. So this is what we need to focus on, classifying them into BCLC B and C, and giving proper sequence of treatment. Doing otherwise would definitely have a negative impact on survival. So this is the guidelines. What you have, if it is unresectable and local regional therapy has been failed, and then we have the systemic therapies. So we had sorafenib, and then we had lenvatinib. These were the two tablets which we had initially. We had sorafenib with whatever phase randomized trials. It improved overall survival, and there was a lot of debate that only hepatitis C positive patients were included, hepatitis B were not included. Having said that, there has been some evidence. There has always been a saying that Caucasians benefit more, whereas the Asians benefit less, and there are multiple ways of debating it. But whatever we had that strong evidence that sorafenib does add life to a patient with HCC. And then lenvatinib had a non-inferiority trial. It did show some numerical superiority, had a better side effect profile for sure. And this is what we have in the present day: lenvatinib and sorafenib. So nowadays, sorafenib is basically offered for patients who are not able to afford lenvatinib. So we all, even now we have generics of lenvatinib. So we offer lenvatinib for majority of patients in view of a numerically superior survival and also a better toxicity profile. So now, having said that, chemotherapy is almost obsolete nowadays unless we have a cholangio sort of a picture. Otherwise, we are not using chemotherapy as of now because we have other active agents. So now we have Nivo Ipi in first line, and we also have Atizo Babe in first line. So these are the drugs which have come up in the first line therapy as of now. And then in the subsequent line, we do have single agent immunotherapies like Pembro single agent, Nivo single agent. We have some evidence for cabozantinib, regorafenib, and ramucirumab only if AFP is more than 400. And of course, sorafenib if we have used first line lenvatinib, even though the evidence is not much. So these are the drugs that we have, and who have failed local regional therapy. We need to offer systemic therapy in these set of patients, especially the BCLCB who have failed local regional or BCLC patients. Okay, so you can see the child pug A part. So you can see the child pug A part. Pembro is only for child pug A, and the moment you go to child pug A and B, we have Nivo and sorafenib being there. So that's quite promising. So child pug B, we have some evidence for nivolumab, and we have some evidence for sorafenib. So child pug B is not an absolute no. We can give both immunotherapy and TKI, and we have evidence for the child pug B category also. So going further, you can see what is the survival. We speak of survival less than a year, 10.7 versus 7.7, and the same replicated in our setting was 2 to 2.5 months shorter. So this makes us to realize that HCC is a disease where the patient doesn't cross 1 year of survival if I am giving only sorafenib or TKI as the only treatment. So there is definitely an unmet need to improve survival in these difficult to treat, especially BCLC B failed on local therapies or BCLC C set population. At least we need to make them cross a survival of median of 1 year, and that's a big thing in HCC. So, so again with the regorafenib, you can see not much benefit, and ramucirumab not much some PFS benefit. So these are marginal differences. However, even these marginal differences in this difficult to treat disease become significant. Otherwise, these minuscules of differences added only will get with a significant difference. So each small differences have been added as far as sorafenib, regorafenib, ramucirumab, all these are concerned. So then comes the immunotherapy that has actually revolutionized the way of treating hepatocellular carcinoma. And let us speak in the coming 15 minutes on what evidence we have for nivolumab in HCC and how strong the evidence is. So, before we have a phase 3 randomized trial, we did have a dose escalation phase and then a dose expansion phase where they had both sorafenib naive and sorafenib progressed patients. And then there was a phase 3 data, first line nivolumab and then nivo EP combination, and then addressing the child pug B cohort. So we have 1, 2, 3, 4, and 5. One is a dose escalation study, then 2 is a dose expansion, both in sorafenib naive and sorafenib exposed patients, and then 3 is first line nivolumab versus sorafenib, and 4 is nivo EP combination, and fifth one is uh, basically the child pug B cohort, whether nivolumab really works even in this select subgroup of population. So this is the CheckMate 040 study. So basically histologically confirmed advanced HCC not amenable to curative resection. So child pug score less than or equal to 7 in the escalation or less than or equal to 6 in the expansion study. Progression on one prior line of systemic therapy or intolerance or refusal to sorafenib, and the AST/ALT less than 5 times and bilirubin less than 3, and the HBV viral load should have been less than 100 international units per ml. So exclusion if there was any history of encephalopathy, excluded, and then if there was significant ascites, excluded, active HBV or HCV co-infection, excluded. And you can see the dose 0.1 to 10 was in the escalation, and then they came down to 3 milligrams per kg 2 weekly in the expansion study. And it is stratified into HCV infected, uninfected, and like that. And objective response rates for the primary endpoint, secondary was again the disease control rate, overall survival, time to response, duration of response, and so on. And of course, they had patient related outcomes and biomarker assessment. And you can see the response rates in a sorafenib experienced and sorafenib naive, and very marginal response rate. You can see with the blinded independent response rates, even as per M resist, just hardly 22% response. 20% response is what all we have as far as immunotherapy in uh, uh, HCC is concerned. So we can just understand how difficult and resistant this particular disease. You have a damaged liver and you have a cancer that doesn't shrink at all. And you can see the overall survival. You can see it's around 15 months, and this is crossing 1 year mark. You saw with sorafenib, the median OS was less than a year, and the moment you add immunotherapy, the median OS is crossing 1 year. So that means immunotherapy does work. With whatever with whatever modest way, it has some benefit, and it helps in crossing nearly 12 months. You can see the median OS being 15 months. And you can see the 1.5 years, the survival is nearly 46% is surviving with nivolumab. So the side effects, anyways, we have endocrine side effects, we have rash, diarrhea that was in par with any other trial. And this is what is interesting as far as nivolumab data in HCC is concerned. They speak of what is called non-conventional benefit. So we all know immunotherapy does not work by shrinking the tumor. So overall response rates or partial responses, complete responses is not the way to think in immunotherapy. We all know when you compare immuno with chemo, the response rates are inferior, and you can see the progression-free survival will be inferior, but they show a significant overall survival benefit. So they don't shrink the tumor, they alter the microenvironment, they improve the immune response, and this impacts on the overall survival. Hence, having only response rate as an endpoint with immunotherapy would be flawed. So we need to see, even in those patients who have progressed on immunotherapy, is there a subgroup on patients who do progress on immuno who are going to benefit? Or should we stop? If there is progression with chemo, we stop as per RESIST criteria. Whereas with immunotherapy, as per M-RESIST, even if there is progression, we may continue, provided a few criteria are satisfied, and we will see which are those criteria in whom we can continue nivolumab in spite of progression. And what is this non-conventional benefit all about? So you can see here the exposure of nivolumab in the sorafenib naive and sorafenib experienced patients, and this is the response rates. As I was saying, hardly much any response rates. 20-22% response rate. What we see, and disease control rates are above 50%. So response rates is not at all the way to go. Assess the efficacy of immunotherapy. Response rates is not the ideal endpoint, and you can see the median duration of stable disease in patients with the best overall response rates of stable disease was 4.3 months. So even in those patients who had a stable disease at a reasonably good progression-free interval, or uh, uh, the median duration of treatment. So this is what the whole thing is about. You can see the overall survival if you can gauge by the response rates. Those patients who have a shrinkage of tumor, definitely they do good. Those who had stable disease, they do better than those who had progression. You can see the median overall survival was not reached in patients who had some sort of a response, and in those patients who had stable disease had a median OS of around 16.7 months, and in those patients who had progressed had a median OS of 8.9 months. And then if you look into the degree of shrinkage, if it is more than 20% reduction, you had the best benefit. Again, 0 to 25% reduction, the survival is around 17.7, and 0 to 25% increase, you can see the survival 11.7. And if there is more than 25% increase, then the survival further comes down. So not just shrinking matters, not just being stable matters, whether it is a mild increase or whether it is a too much increase, whether it is 0 to 25% increase, or whether it is more than 25% increase. There is a difference in survival. This is what we call as non-significant benefit even in those patients who have got progressive disease. So these are the hints that we get from the way immunotherapy acts. That is, even in those patients where we see disease progression, even in this set of patients, we see some benefit from immunotherapy. Therefore, just a reflex action of changing the immunotherapy just because we had some mild progression is not correct. So these are the types of disease progression they have classified for what is called as non-conventional benefit. You can see the first criterion where there is progression with new lesion followed by decrease in target lesion of more than or equal to 10%. You had new lesion, but the target lesion did reduce later. And criterion B was progression of target lesions followed by decrease in target lesion of more than 30%. So the increase in target lesion was basically a pseudo progression. Later on, it did shrink more than 30%. And then the third one is progression of target lesion with new measurable lesion as well. So just to put in a simple way, so you can see that if there is some sort of shrinkage of the target lesion with appearance of new lesion, still that subgroup is benefiting. Even if there is radiological evidence of progression, if there is some sort of shrinkage later, this subgroup is benefiting. Therefore, the take home message is if in those patients who receive immunotherapy, just a mere radiological progression should not be taken as failure of immunotherapy. On the other hand, we also need to assess clinically and also other sort of imaging like what has happened to the contrast enhancing, what has happened to the necrosis part. All these dynamic features also matter before declaring them as progressive disease. So this is one of the first trials where they indicated that even in those patients where there is obvious evidence of progression, if we follow them up, there is further reduction in the disease burden, and that reflects in survival benefit. You can see the blue and the orange curves. Patients who have a non-conventional benefit, you can see a median OS of around 18.8 months, and those patients who did not have a non-conventional benefit, the survival comes down to 8.4 months. So these are the patients who had progression on immunotherapy. But if you look into either of the three criteria, if they're fitting in, they are benefiting as well. So this just indicates us that resist is not the only way to go. We need to assess other parts of response, clinical response, radiologically, and we also need to look into the other dynamic parts like amount of necrosis that has happened, with what has happened to the contrast enhancement, AFP, all these matter before we decide progression on immunotherapy. These are the patient-related outcomes. We can see that immunotherapy hardly causes compromise in quality of life. So basically, the summary was that so nivolumab demonstrated meaningful overall survival in sorafenib experienced population. Overall survival corresponded to the best overall response and the degree of tumor reduction, and the non-conventional clinical benefit, including tumor reduction and stabilization in patients with best overall response of progressive disease, was associated with improved OS. So this was the first time where this particular study indicated that continuing immunotherapy, even in those patients who have disease progression, would benefit and would give them survival benefit. So therefore, resist is not the plain criteria to just change or stop immunotherapy. You need to have other ways of assessment. So then, going further, so adding nivolumab did make patients cross the mark of 1 year overall survival, uh, uh, and then even in those patients who were sorafenib exposed. So uh, nivolumab exhibited limited antiviral activity, so that we know. So the safety profile was fair enough, and the response was there irrespective of HBV or HCV positivity, unlike sorafenib, where it worked more in the HCV positive subgroup, whereas immunotherapy works both in HBV or HCV positive, and also whether PDL1 was positive or not, it did show a promising benefit. Then, so this is a CheckMate 040 trial where they had three arms of nivolumab 1 milligram per kg plus ipilimumab 3 milligram per kg, and then arm B was 3 milligram per kg nivolumab plus ipilimumab 1 milligram per kg. Both were given Q3 weekly for 4 weeks, followed by nivolumab maintenance 240 milligram 2 weekly. This was basically in advanced SCC sorafenib treated intolerant or progressors, and uninfected HCV infected or HBV infected were all included. So basically, this was advanced HCC sorafenib treated intolerant or progressors. So, and then the third arm basically was Nivo 3 milligram per kg and IP 1 milligram per kg, which was given 6 weekly, and nivolumab was given 2 weekly. So these were the three arms: Nivo 1 milligram per kg, EP 3 milligram per kg in arm A, 3 milligram per kg Nivo, and 1 milligram per kg EP. So the whole idea is that ipilimumab higher doses causes more toxicity. I would be happy to give ipilimumab of 1 milligram per kg than 3 milligram per kg, because the diarrhea, the colitis part goes up more when we increase the dose of ipilimumab, and that's the reason why we are doing this interchanging 1 and 3. And you can see the overall survival in arm A. It's about 22.8 months, where we have used Nivo 1 milligram per kg and Ipi 3 milligram per kg. So ipilimumab, if we use at 3 milligram per kg, has shown a better overall survival as far as this trial is concerned. And if you look into the toxicity part, especially the diarrhea and colitis part, it is nearly 10% of any grade and 6% in comparison to 2% if we use a lower dose of ipilimumab. So this indicates that using ipilimumab 3 milligram per kg does benefit in terms of better overall survival with with increase in toxicity, especially the diarrhea and the colitis part, and even you can see the hepatitis part and the adrenal insufficiency, the rash part. So all are little higher as far as Nivo Ipi, especially ipilimumab when it is 3 milligram per kg. Then we had this trial presented in the last year ESMO, where they used in those patients who are locally advanced and metastatic, unresectable HCC, who were naive for previous therapy, and they're stratified based on the region, PA performance status, whether there was a macrovascular invasion or extrahepatic spread, and the baseline AFP. And they're randomized to atezolizumab plus bevacizumab versus sorafenib. And this was one of the landmark papers where there was first line head-to-head comparison of atezo-bev versus sorafenib, and the co-primary endpoints were overall survival and PFS. And you can see the median overall survival in the atezo-bev arm was not reached, and compared to the sorafenib arm, it was 13.2 months with a hazard ratio of 0.58 with a statistically significant p-value. And you can see the side effect profile in the, and even the overall response rates were better in that. So I am being Ray 150. So this led to the approval of atezo-bev as one of the treatment of choice for the first line hepatocellular carcinoma, with a statistically significant and clinically meaningful overall survival, progression-free survival benefit, and an improved response rates with an acceptable toxicity profile. So with these, I would like to conclude with a few take-home messages. Number one, we need to classify HCC into BCLC A, B, C, D. The moment it is BCLC A, we need to look in for resection or transplant. And the moment it is BCLC B, C, and D is basically this where the liver failure is taken up, and nothing much we can do about the cancer as such. And BCLC B and C are have to be classified properly. If it is BCLC B, I should not deprive them of local therapies. If feasible, we always have to put in some sort of local therapy, especially TACE plus or minus RFA plus or minus microwave ablation. And the moment there is failure of local regional therapy, then I need to put in systemic therapies. And BCLCC, I need to address properly by systemic therapies. So in the first line, now we have approval for lenvatinib, sorafenib, and atezolizumab, and there are trials of Nivo-EP coming up. And in subsequent lines, we always need to expose them to immunotherapy if we have not exposed them in the first line. So this proper sequencing and exposing them to local therapies whenever feasible is important. And as far as response assessment in immunotherapy is concerned, it is not a plain RECIST criteria. As we have seen very clearly in the data of what is called as non-significant benefit, even in patients who have disease progression. So even if there is radiological disease progression, we need to look at other parameters like AFP, clinical improvement. We need to look into the contrast enhancement, whether it is what the amount of necrosis. All these are important before we jump on and change the drug from an immuno to other drug. So with this, I would like to conclude, and I would thank everyone for patiently listening, and I would thank BMS for providing the opportunity to have an educational discussion on the topic. Thank you so much. Over to you.